Hi, my name is Linda Herrera, and today we will be going over two case scenarios that will help us to bring together the information that we have learned over this past unit. First, I will be going over case 1 with you. We are given this description. A newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. The question then asks, which diagnostic would be the best to distinguish between a urea cycle disorder and a disorder in beta oxidation? We are then given multiple diagnostic tools including A, blood glucose, B, urinary acids, C, serum fatty acids, and D, plasma glutamine. After doing some research, in the case of this patient, the best diagnostic tool would be D, plasma glutamine, to differentiate between a urea cycle disorder and a disorder in beta oxidation. Urea cycle disorders are inborn errors of metabolism involving deficiencies of enzymes required for ureagenesis. These disorders manifest as acute or chronic hyperammonemia. To manage a urea cycle disorder, medical steps are taken to reduce the ammonia concentrations in the blood. Severity of the urea cycle defect is influenced by the position of the defective enzyme in the pathway. Severe deficiency or total absence of the activity of the first 4 enzymes in the pathway, which are carbamyl phosphate synthetase 1, ornithine transcarbamylase, citrullinemia type 1, and argininosuccinic aciduria, or the cofactor producer N-acetylglutamate synthase, and NAGS, will result in the accumulation of ammonia and other precursor metabolites during the first few days of life. Infants with urea cycle disorders appear to be normal at birth, but rapidly develop signs of lethargy, hypothermia, hypoventilation, etc., just like our patient described above. A concern is that newborns usually are discharged from the hospital within 1 or 2 days after birth, so symptoms of urea cycle disorder often develop when the child is at home and may not be recognized in a timely manner. In most patients, glutamate levels will rise when ammonia levels are elevated. Fatty acid oxidation disorders can result from a transport defect of fatty acids or a defect in an enzyme involved in the fatty acid oxidation pathway. Patients with fatty acid oxidation disorders usually present to have hypoglycemia without ketosis during episodes of decreased carbohydrate intake. We are then given more information on the patient. A full blood workup was ordered for this female, and the data is presented. We are told that the initial blood ammonia level was elevated at 314 Ug per deciliter. The normal range is 17 to 80 Ug per deciliter, and that her levels rapidly rose to 600. Her urine orotic acid level was also elevated at 473 umol per liter of creatine. The normal level is 0 to 3. The plasma citrulline level was normal. We are then asked, in this patient where orotic acid levels are elevated, list one urea cycle enzyme that is most likely deficient and one urea cycle enzyme that is least likely to be impaired. After doing research, I came to the conclusion that in this patient, elevated levels of orotic acid could most likely result from an ornithine transcarbamylase OTC deficiency, where carbamyl phosphate elevates and is used as pyrimidine synthesis in the cytosol, resulting in elevated levels of blood ammonia and urine orotic acid because excess carbamyl phosphate is converted into orotic acid. OTC deficiency can occur as a severe neonatal onset disease in males and rarely in females, and a post-neonatal onset partial deficiency disease in males and females. It seems that in the case of our patient, she may be one of those female cases to get one of those rare female cases to get the neonatal onset disease, as she was normal at birth but becomes symptomatic within 24 hours after birth, which is characteristic of neonatal onset disease of OTC deficiency. These infants are usually ill by the time they receive medical attention, such as our patient. After successful treatment of neonatal hyperammonemic coma, these infants can easily become hyperammonemic again despite appropriate treatment, and typically require a liver transplant by the age of 6 months old to improve quality of life. The post-neonatal onset OTC deficiency can present from infancy to later childhood, adolescence, and even adulthood. These infants usually become symptomatic when their diet is switched from breast milk to formula or whole milk, as breast milk contains less protein than infant formula or cow's milk. Raised orotic acid levels help to distinguish OTC deficiency from carbamyl phosphatase synthetase 1 deficiency. With this information, we can consider carbamyl phosphatase synthetase 1 to be the enzyme of the urea cycle that is least likely to be impaired in this patient. For my second case scenario, I chose to answer case 3. The description is as follows. A 47-year-old man presents with severe pain in his right great toe. He is unable to bear weight on his right foot, and there was no apparent trauma. He reports the pain started last night and continued to increase in severity. Based on his physical exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn and a urine analysis is performed. The results from this individual are listed below. We are then shown a chart listing the results from the tests. The patient's plasma urate is 10.5 mg per 100 milliliters. This level is above normal, and the urinary uric acid is 215 mg per 24 hours. This level is below normal. We are then asked, what is the best explanation for the presentation of gout in this individual, and please explain why the other choices are not consistent with the data, or what additional information you may need to decide the root cause. We are then given the options of 1. Overproduction of purines, 2. Decreased salvage of purines, and 3. Decreased urinary excretion of uric acid. Based upon the results of the samples, we can conclude that the cause of this patient's gout is option 3, decreased urinary excretion of uric acid. Gout is a urate crystal deposition disease that results from a metabolic disorder, hyperuricemia, and the consequent deposition of urate crystals in joints such as our patient's right great toe, soft tissues, and organs. Diminished renal clearance of uric acid promotes hyperuricemia in at least 90% of patients with gout. This seems to be the case in our patient, as his lab results indicate high levels of plasma urate and low levels of uric acid found in the urine. The other two options are incorrect, because if the cause of this patient's gout were overproduction of purines, then we would see an increased plasma urate and also increased urinary uric acid, which is not the case. The other option, decreased salvage of purines, which show in the blood work as low urinary uric acid and low plasma urate, which again is not the case. We are then given more information. After further discussion with the patient, he tells you that he recently switched from diet soda to regular soda because he read that fake sugar diet soda was bad for him. He tells you he drinks 4 to 5 liters of soda a day. We need to keep in mind that the primary sugar in most sodas is fructose and high fructose corn syrup. The last question we are asked is, what is the potential impact of this dietary modification on the presentation of gout? The mention of switching from diet soda to regular soda raised a red flag. An increase in plasma urate levels is the result of a purine or fructose-rich diet, among other factors, one of them being most commonly insufficient excretion. With the new information of a large intake of soda, this could play a large role in our patient's case in conjunction with the lack of urinary excretion of uric acid, because fructose causes mostly the depletion of ATP, increasing the generation of and release of uric acid. Thank you for listening and have a nice day.